Good morning. Today we're going to be going over chapter 15, the Adrenergic Agonist and the Antagonist. So I'm going to really touch base on the objectives and the key points, and then just go over and make sure you have gone through the terminology and the objectives in your book, and also follow along with your NCLEX questions and the study guide and the questions at the back of the chapter. So with that being said, I'm going to go over some key points, and to have drugs that stimulate the sympathetic nervous system are actually called adrenergic agonist. Adrenergics are sympathetic, actually mimic the sympathetic neurotransmitters, the norepinephrine and the epinephrine. Okay, you'll see on slide 2 where it's referring to the adrenergic agonist. They act on one or more adrenergic receptor sites located in the effector cells of the muscles, such as the heart, the bronchiole walls, the gastrointestinal tract, the urinary bladder, and the ciliary muscle of the eye. The 4 main receptors are the alpha 1, alpha 2, beta 1, and beta 2. So you'll know that the alpha adrenergic receptors are located in the blood vessels, eyes, bladder, and the prostate. Now, when alpha 1 receptors in the vascular tissues of the muscles are stimulated, the arterioles and the venules constrict, increasing the peripheral resistance and the blood return to the heart. It actually causes the blood pressure to go up. So, and the alpha 2 receptors are located in the postganglionic sympathetic nerve endings. When stimulated, they inhibit the release of norepinephrine, leading to a decrease in vasoconstriction. So actually, the results show a vasodilation, and it lowers the blood pressure. You'll see a lot of the different blood pressure medicines will affect those. And then the beta 1 receptors, you'll see that on slide 3, are located primarily in the heart, but they are also found in the kidney. The stimulation of the beta 1 receptors increases myocardial contractibility and heart rate. So the beta 2 receptors, they're found mostly in the smooth muscle of the lung and the GI tract and the liver and the uterine muscle. Stimulate the beta 2 receptor, and it causes 1, the relaxation of the smooth muscles of the lungs, and 2, it decreases the gastrointestinal tone and mobility. So you want to know the activation of glycogen lysis in the liver, and for the relaxation of the uterine muscle. So because the drugs that act on the beta 2 receptors, it also causes the blood sugar to rise. And the other adrenergic receptors are the dopaminergic, are located in the renal and the mesenteric, coronary, and cerebral arteries. When these receptors are stimulated, the vessels dilate again, the blood flow increases, only dopamine can activate those receptors. Now, after the neurotransmitter has performed its function, the action must be stopped to prevent prolonging the effect. So transmitters are actually inactivated by one, reuptake of the transmitter back into the neuron, and then two, the enzymatic transformation of the degradation of the three, the diffusion away from the receptor. Now, the two enzymes that are inactive, that inactivate the norepinephrine, is what you would usually hear is MAO inhibitors. It actually stands for monoamine oxidase, and that's rare. They're rarely used anymore because they counteract with so many drugs, which is inside the neuron. And two, the catechol methyltransferase, which is the COMT, which is outside the neuron. Now you'll see on slide 6, the drugs can prolong the action of the neurotransmitter by either one, inhibiting uptake, or two, inhibiting the degradation by the enzyme action. So it actually is going to be inhibiting the absorption or the uptake, or it's going to inhibit the basically breakdown. And that's what that means of that particular by that enzyme action. So sympathetic, on slide 7, sympathetic drugs are classified into 3 categories according to their effects on the organ cells. Categories include 1, direct acting sympathetic symptomagnetics, and 2 is the indirect acting sympathomedics, and 3 is actually mixed acting sympathomimetics. And now you got on slide 8, we're talking about the catecholamines, are chemical structures of the substance that can produce a response. It basically mimics the sympathetic response. Now with the examples, where the endogenous and the catecholamines are epinephrine, norepinephrine, and dopamine. So you'll always know those 3 are the things that actually work on the excuse me. Now the sympathetic catecholamines are isproterenol and the dopamine. Many of the adrenergic agonists stimulate more than one of the adrenergic receptor sites, Many of the, an example, excuse me, I had I want to repeat that. An example of the epinephrine, which acts as the alpha 1, beta 1, and beta 2 adrenergic receptor sites. The responses from the receptor sites include increase in blood pressure, pupil dilation, tachycardia, and bronchodilation. Just know that the epinephrine can cause renal vasoconstriction. Always monitor the INOs, like we have talked about in clinicals, in our case studies. Anything that will cause a mimic of the fight or flight, you're going to have less urine output. So you want to make sure that doesn't affect that much, because you still have to watch. You have to have at least 30 milliliters an hour the output, or your kidneys aren't functioning properly. So drugs that affect the multiple adrenergic receptors are non-selective. You can see that on slide 9. Now, the drugs that affect a specific receptor are selective, because you have the alpha 2 drugs are central acting and produce vasodilation by stimulating alpha 2 receptors in the central nervous system, leading to a decrease in the blood pressure. And then drugs that block the effects of the adrenergic neurotransmitter are called adrenergic blockers. Adrenergic antagonists are sympatholytics. Adrenergic and agonists act as antagonists by blocking alpha and beta receptor sites. Most of the adrenergic antagonists are the adrenergic blockers, block either the alpha receptor or the beta receptor. They block the effects of the neurotransmitter either directly or by occupying the receptors, or indirectly by inhibiting the release of those neurotransmitters, norepinephrine and epinephrine. Now, drugs that block or inhibit the response at the alpha adrenergic receptor site are called alpha adrenergic antagonist, and the adrenergic blockers are adrenergic alpha blockers. The alpha blocking agents are considered to be divided into 2 groups: selective alpha blockers that block the alpha 1, and the non-selective alpha blockers that block alpha 1 and alpha 2. The alpha blockers can be used to treat peripheral vascular disease, and they're also helpful in decreasing the symptoms in the benign prostatic hyperplasia. And that's what that is basically saying. It helps when it's not actually prostate cancer. It actually helps decrease the size of hypertrophy, which is enlargement. You just refer to the slides on that. Now, your beta blockers decrease heart rate, and it decreases the blood pressure, and usually follows. Now, you also want to make sure when you're taking beta blockers, make sure that over time it doesn't actually cause some residual heart block by reducing and causing bradycardia. So beta blockers, when they are non-selective, blocking both beta 1 and 2 receptors, not only does the heart rate decrease because of the beta 1 blocking, but the bronchoconstriction also can occur. Non-selective beta blockers block the beta 1 and beta 2 and should be used with extreme caution in any patient who has a chronic obstructive pulmonary disease, or basically COPD, because it's going to exacerbate that, or asthma. So with intrinsic sympathetic activity, which is ISA, it's the ability of the certain beta blocker to bind with the beta receptor to prevent strong agonists from binding to the receptor, producing a complete activation. These agents may be recommended for patients experiencing the bradycardia already. Now, the beta blockers are useful in treating mild or moderate hypertension, angina pectoris, and the myocardial infarction. Now, beta blockers should not be abruptly discontinued, but rather should be tapered off over a 1 to 2 week period to avoid abrupt tachycardia and hypertension, severe angina, dysrhythmia, or even an MI. And now, drugs that block and release norepinephrine from the sympathetic terminal neurons are called adrenergic neuron blockers. Okay, the clinical use of neuron blockers is to decrease the blood pressure. So now, just remember, those are the key points to know. And just remember, you want to look over the terms and any side effects. Thank you very much. And we're going to go on to the next chapter.